Okay. We're going to complete the chapter that we started last night. We're going to do burns. Burns are a whole topic for itself. And after that, we'll move on to whatever else was scheduled for tonight. Burns. Okay, in EMS, we do see a lot of burns. Okay, it's very common. People get burned. Well, when we speak now, we're speaking about generalized burns. We're not really going to specify how the burn occurred. That we'll get to a little bit later, because there are some slight differences. But in general, we talk about what's known as thermal burns. These are burns that occurred from a heat source, all right? It doesn't matter if somebody poured hot chicken soup over their hand, or they touched the element of an electric heater oven thing, or they got steam, in their face, or some other, doesn't matter. It's all very much similar, it's all considered burns. So the first thing I'm going to teach you is how we classify burns. And every EMT needs to be able to understand the differences between these three classifications of burns. And it's not difficult. Okay? Burn number one is known as a superficial burn. You do need to know both ways of describing it. It's called a superficial burn, and the simple day-to-day way we describe it is a first-degree burn. You need to know both words. Superficial burn or a first-degree burn. How would I describe this? Very simply. You went outside without putting on any sunscreen, if you have a complexion such as mine, and you went out into the boiling heat of the sun, you walked around, and you got red on any exposed part of your body. That redness, that sunburn, if you like, the redness, that is the characteristic of a first-degree burn. Again, it doesn't matter how they got it. They could have spilled hot coffee over their back, their lap, their legs. It doesn't matter how the burn occurred. You come there, somebody shows you a body part, and it is red, and you can assume or deduce that there was a source of heat that caused this redness, that's a first-degree burn. All right? So you must understand this.
Red pigment.
Red, not pigment, a redness of the skin. Okay? Pigment would imply that a color had been applied to it. So I don't like the word. The skin has turned red. All right? From some sort of heat source. All right? That is a first-degree burn. That is known as a superficial burn. And that is an extremely painful burn. Okay? So, as you get older, you get a little wiser. Right? You realize that, even though you're wearing a baseball cap and you're walking around, in the Dead Sea area, but your ears and your neck is not covered by your baseball cap, all right? So you have to put on the sunscreen. You have to understand, right? Short sleeve shirt, okay, that's great. You gotta sunscreen up the parts that are exposed. So that's your first-degree burn. Again, it has nothing to do with a sunburn. I'm just giving you the number one way to remember. So if you're reading in a text or in an exam or whatever, and they're talking about redness to the skin, redness from a burn, doesn't matter how they got it. The skin is red. How are we classifying the burn? First degree. That's simple. Superficial burn. Number two is known as a partial thickness burn. Partial. Partial means not all the way, just part. And we call it, day-to-day medicine, we call it a second-degree burn. Second-degree burn. What is the difference? How do I differentiate between a first and a second-degree burn? And the answer is the presence of blisters. Once the skin blisters up, and you see these white It doesn't matter what size. Could be very small, could be huge blisters, could be they popped, could be the patient popped them. All this doesn't matter. The fact is there is redness and there are these blisters which are typically white. Second degree burn. This is a more serious burn. This is going to be okay. We got first degree, we got second degree. Partial thickness. Again, extremely painful for the patient, and we'll talk about how we're going to treat it, what we're going to do for these patients. Okay. Third burn is called a full thickness burn. Alright, superficial, partial thickness, full thickness burn. A full thickness burn that we call, again, easy to remember, third degree burn. This is where the skin, the flesh has burned, and if you look here in the picture, you see all the layers, all the way down to muscle, sometimes including the muscle, has burned. Nerve endings have burned. This is the most serious type of burn that we're going to talk about in EMT class, and you will see either black or white charred. You've seen white if you ever use coals on a barbecue, and after they've been there for a certain amount of time, they turn white. Okay? That's the same concept. The skin will be completely burned. Now, well, this is white from a burn, not white from a blister. It's burned all the way down. You can sometimes see bone. Okay? It'll look black, like a piece of steak that's been left on the grill way too long. Okay? I don't just mean way too long, it's been overcooked. I'm talking about charred. Right? You leave a piece of meat on the grill and just let it stay there, it's going to turn black and crusty. That's a third degree burn. I just want to address this because I don't like it. So I'm going to address it. And it says it in every textbook, and it's a big mistake. So I want to clarify it and make sure you understand. There's no such thing as a third degree burn without second and first accompanying it. Every burn always has the ones below it. Okay? The only way you could get a third degree would be like to take like a cattle prod thing with a boiling hot lead end and just touch straight down into somebody's skin and remove it. Yeah, there you may get a third degree only burn, but typically your thermal burns that you're going to see in the field are going to be accompanied by second and first degree burns.
So they get worse?
So,
close to it, adjacent to it.
it'll actually be more like a bullseye situation. Okay, around it. Now, this is why I want to address this, okay? Every textbook you read is going to tell you that third degree burns are not painful. That is not true, okay? First and second degree burns are extremely painful. The point where they have third degree burns, they may not feel any pain there. You understand what I'm saying?
Is that because all the nerves are
Because
gone?
the nerves have been burned and there's no feeling being transmitted. But right around it, they're going to be in tremendous amount of pain. So I just don't like that you'll see this, and if it doesn't get explained, you'll just walk around thinking, oh, third degree burn, yeah, they're fine, they're hunky-dory, right? They're sitting there, you know, playing the piano or something. No. If they've got a third degree burn, they will be in extreme pain from the first and second degree burns that are surrounding it. Third degree burns you're not seeing every day. Okay? I will say, I don't do well with medical statistics because I don't care enough to, but I would say from my practice, 90% of burns are first and second degree burns. Okay, that is what you will see on all the burn calls that you go to, okay? Third degree is rare, right? And you can see why, right? First degree is superficial, second degree, okay, it's partial thickness, we're getting through, some of those layers, but to burn all the way down to the muscle, burn all the way down, sometimes burn the muscle and see bone, that's not happening every day, all right? But again, you must be prepared for all three. You have to be able to classify what burn you're bringing in.
Does partial thickness penetrate the skin, or just blisters?
Yes. Yes. Here's a picture of your
Yeah,
skin.
you
Here, here's
mentioned
3 layers of the skin.
You mentioned the blisters, I wasn't sure. So
Yes,
blisters, and it could be.
Yeah.
So full thickness is the amount of skin.
Right, all the way down. Okay. So this is a picture, you can't really see it because the lights are on, but this is huge blister. You see this blistering?
That's a torso? Ooh.
Yeah.
What?
Okay, you see that?
That used to be black or white?
I get black. Alright? Lights. Thank you. So, thermal sources of thermal burns could be any of these things that you see here. Whether it's fire, whether it's radiating heat, steam, hot water. These are all thermal burns. They all do the same thing. They all cause similar damage. Electrical burns we're going to speak about. A little bit different. And chemical burns we'll talk about also. They're slightly different.
And friction burns? What are they categorized?
They're just like thermal burns. They're just going to be the same. They're most of the time just going to be first degree. Okay? Alright, so I want to draw something on the board. I want to... Okay, so we're going to learn the rule of nines. Okay, this is something that every EMT needs to be familiar with. I just don't like the way they teach it in the textbooks. Okay? So, the rule of nines, I'm going to teach you my way of doing it. I'm going to show you what you should draw on the back of every test sheet that you get. Remember I said when you get a test sheet you may want to draw and write stuff. This is something that's worth writing. Okay? So I'm going to show you a very simple diagram how to remember the rule of nines. Okay? So we're going to look at the board. You can stay in your seats. We're going to come over here. Alright. So the rule of nines works like this. It's giving you a way to calculate approximately how much body surface area, and this is an official medical abbreviation, BSA, body surface area, has been affected by the burn. Okay? Because if you come into a hospital, they're going to want to hear from you, what is your estimation of how much of the body has been burned? Okay? So, this is what I advise you to do. Okay? You draw a stick figure such as this chap here. Okay? You can give him a face if you want. He's not happy because he's been burned. Okay? The rule of nines, okay, this is as difficult as the mathematics is going to get in EMT school. Okay? If you go to medic school, yes, you're going to have to really have your math up there, okay, to be able to do dosing calculations for medications. This is as far as the math is going to go. Basically, what math would say is that 9 multiplied by 11 equals, look at that, we got mathematical genii here, right? So this is a rule, this is a true rule. Okay, 9 multiplied by 11 equals 99. Which means, very simply, that there are 11 regions in the body that I can assign 9% to. Okay, and once I've assigned all 9% to my 11 regions, I have reached 99% of the body, and the 1% we'll get to in a minute. So here we go. This is what I suggest you draw. I would not do the face necessarily. Yes, question?
No, I think the hand was 1%, right?
No. Alright, here we go. So, the head, this is for an adult. This is for an adult patient. Okay? Adult. Okay?
Why are you breaking it up by 11 though?
Because I need to get to 100% of the body. And it's called the rule of nines.
Oh, okay.
So there are 11.
No, they're close.
No, but-
I think it's between 11, no, 11
How many different regions are there?
11.
Oh, there are
11.
11 regions,
I'm
okay.
going to show you.
Oh.
Ready? Here we go. The whole head, front and back, is worth 9%. Each arm, front and back, circumferential. That's a word we use in burns. Circumferential. That means all the way around is worth
9%.
9%. So now we've got 3 of our 11, right? The abdomen. No, let's start with the thorax. The thorax, front or posterior, and the thorax anterior are each worth 9%. So this is from the neck and down all the way until the diaphragm. 9 posterior and 9 anterior. Great. Now we have the abdomen. Abdomen. Anterior abdomen is worth 9. Posterior abdomen, which means back and buttocks, are also worth 9. How many have we got so far? 7. We're getting there. Each leg
9.
has an anterior and a posterior portion. Okay? So you will have 9 anterior, 9 posterior for each leg.
Oh, it'd be 4.5. Oh,
Okay? So, how many 9s do I have?
11.
I have 11 9s. So I've covered the entire body. Now, how do we use this in real life? Okay? How do we use this in real life? The way we use it in real life is that it's very rare that a patient's entire leg will be burned, right? Very often it may be from pelvis to knee. So if I know that the entire anterior portion is 9%, then half of the leg will be 4.5. And so on and so forth. If the entire arm is 9%, that means anterior, posterior, all the way around, and they only burn from their elbow to their wrist, well, that's a quarter of the 9, okay? This is something you have to work out. On state exams, you will only be tested in round numbers, whole 9 categories, okay? It will give you body parts that got burned, and the answer must be a multiple of 9, all right? So if you're writing, 32 and a half, you made a mistake, all right? It's gotta be in the 9 times table. So that's a clue.
Could be 9 and 4.5.
On a state
Or it
exam,
won't be 4.5?
it won't be. It will only be whole 9s. So, I hear you asking, how do we get to 100%? Because there we're only showing 99%.
Shut up. Video.
So the 1% is the genitalia, okay, the bris area.
Speak for yourself.
Now, when I speak to a class of African American students, I have to say, brothers, I understand. It's not true, but we have to accommodate even the Asians, okay? So we have to make, a
Round.
right. We take a median sort of number that accommodates everybody, and that's called the 1%. In medicine, that area is known as the 1%. A person's 1%. It's just a way, a sort of a more adult way of saying that area. Okay, it's commonly used. The pediatric rule of nines you do not need to know for EMT school. And I find personally this one extremely complex to understand. So I have all of it there. That's something you can reproduce quickly on your paper. And whatever they throw at you, you calculate. All right? Okay, as well as understanding how much of the body has been burned, we also have to remember that there are 5 locations that will up the severity of the burn and make it into a critical burn, just based on where they are in the body. Those 5 locations are listed here: hands, face, feet, and genitalia. Was that 4? Yeah. Hands, face, feet, and genitalia. These 4 locations automatically bump the patient up to critical status.
Why more than the thorax?
Why feet and feet?
This is the rule.
If what happens?
Okay, patient got burned, right? And we need to now assess the amount of BSA, body surface area, that was burned. After that, we have to decide, is this a critical burn? The reason we need to know that is because we have to, especially in New York City, we have to decide, can we go to a regular hospital or do we need to go to a burn center? Only critical burns go to a burn center. So what I'm telling you is that hands, face, feet, and genitals automatically get bumped up to critical status.
No matter the.
No matter the amount or the size of the burn.
It's all together or either one?
Any one of these 4 places.
So the guy burns his hand, he's going to a burn center.
Yes. Whereby if he has a much larger burn and it's on his arm or his leg, may not be necessary.
Does it make a
Okay.
difference if it's first, second, or third degree?
Not really. First degree, we generally don't take that seriously. So when we're talking about critical, I'll show you in a minute. I'll show you some numbers, all right? Again, you know, there's different textbooks, different things. New York City says over 60 and under 5, those are critical burns also. Okay, New York City.
New York State is 55.
All right, so what?
New York
The
State
patient.
55?
Yeah, 50, 55. That's-
For the test, what are we gonna say?
They won't ask you that. Alright, so this is basically a chart. I don't like to get into too much reading on charts and things like that, especially if I didn't make it. But what I would emphasize are things like this. In order for a first degree burn to be considered critical, you need it on 75% of your body. That means that you went out in a Speedo, okay, and you lay down on the beach somewhere in the Mediterranean, okay, and just waited for it to happen, okay? And then,
And you turned over in the middle.
oh yeah, you had to turn over, sure, okay? And yeah, you can get over, yeah, so you'll definitely get over a 75%. If you do that, that's a critical burn. So you understand if someone gets a first degree burn on their arm, right, we're nowhere near 75%. This is not a critical burn.
Okay, the burn go from first degree to second degree on its own, without being in the sun, let's say.
Well,
Overnight.
it's not really on its own.
Burn.
Burns will sometimes, if untreated,
Right.
progress. Yeah. Okay? A second degree burn, to be critical, we're looking at greater than 30%, except in these 4 locations, hands, feet, and genitalia, then they get bumped up right away.
What percentage?
So it's either or.
1% on the hand? It's critical?
Second degree anywhere, hands, face, feet, genitalia, if there's second degree, it's critical burn.
Oh, that was 27.
So it's either or, not both.
Or 30% in other parts of the body. Okay? And that we do see.
So, I mean, technically a blister on a finger would fall into that
That would
category.
fall into hand, yeah.
Right.
Okay, again, I can't
Use
answer
your judgment,
the question, what would I do, you know, in certain circumstances, we're not getting into that.
I'm just
I want you to
technically
just have a general overview that we're looking for amount of body surface area that has been affected. We also want to know, is it a critical burn? Okay? Third degree burn is anything greater than 10% of the body anywhere. Okay, is critical burn. And again, anything to these four locations: hands, feet, and genitalia. Anywhere, okay? Again, first and second, if there's a burn in the respiratory tract, and we'll probably talk about that a little bit later tonight, that's automatically a critical burn.
Inside?
Yeah. Yeah. You only know that they've burned inside because you will see if they have any facial hair or even a nose hair or so that's singed. And
So they swallow chemicals?
no, usually it's from like some sort of the one case that I remember clearly was a guy trying to fix an air conditioning system in a very large public place at a time when there were thousands and thousands of people in there, and he was cleaning the wires with some sort of metal brush and somehow shorted and it exploded in his face. And there was an electrical,
And he inhaled.
yeah, and he inhaled. You can't not,
Right.
you're going to inhale. So that would be, you know, we'll talk about that again in a little bit.
Why does the first degree burn not say circumferential burn in the critical block?
Because it doesn't matter, I guess.
Again, if it's less than 75%, it won't make it critical. Circumferential burns are critical if they're second degree. That means that they go all the way around any particular limb or body part. Okay? So how do we treat burns? Right? That's our job. We need to treat burns. So the first thing is always the same rule: stop the burning process. If somebody touches something or spills boiling water or chicken soup over them, and now the chicken soup is not being poured on them, the burning process is still continuing. Okay? Just because they took their hand away from the
Elements.
source, it doesn't mean the burning has stopped. Just the opposite. The burning is continuing. Okay? Through the skin. So, your job is
Stop it.
stop the burning process. That is your job. Okay? I can say, in all honesty, that I have seen the craziest home remedies for treating burns. I don't even have time to list all of them or even some of them. I mean, crazy, crazy stuff that you would not even believe. Okay? I can't make this stuff up. As far as you're concerned, as EMTs, the only treatment for a burn is cold running water. Let me repeat that. Okay? Cold running water. Don't ask me, I heard, or I thought, or my grandmother said, or I did. No.
So no garlic?
No, I don't want to hear 'em. I don't want to hear 'em. Again, should I say it a third time? The only treatment for a first, second degree burn, as far as you're concerned, is cold running water.
How cold?
Okay? Just whatever comes out of the faucet or the shower. Okay, we'll get to this in a minute. Sometimes the burn is so severe.
How do you do that while transporting?
Slowly. You're in the house right now. You didn't transport yet. Sometimes the burn is so severe that jewelry, watches, clothing actually adheres to the skin. Do not try to pull it off. Okay? Because you will schlep off skin with it. And we don't want to make things worse. You can cut away at loose clothing, but you do not. But you do not pull at clothing or jewelry. Okay? Next. You need to cut away and expose the burn portion of the body, okay? You can't leave the pants and they tell you, yeah, my leg is really painful because I spilled, this great big Shabbos urn of boiling water on there, and you're like, oh, I don't want to take the pants off or whatever. No, it doesn't work like that, okay? You need to expose. If it's a large area, they need to be in the shower, okay? Again, not a bath, not ice, cold, running water, okay? Let the water run over the burn. Okay, this is something that you
For
have
how
to
long?
understand.
How long?
It's just 15-20 minutes.
As long as you can. As long as you can, till you're ready to make the transport, till you stop the burning process. If it takes you 20 minutes, then better to wait on scene the 20 minutes, at least give them some sort of comfort. You asked, how do we do this en route? So there's two methods. One method is to wrap the burned area in moist, sterile dressing. Okay, so you'll have these large burn sheets, which you will moisten with sterile water you're carrying in your trucks, and you will wrap the burn in these burn sheets, and that will keep it moist, at least wet, will give them some pain relief. Obviously, you should call for medics to provide analgesia, to provide real pain relief, because burns are extremely painful. Okay, I mean, Baruch Hashem, I haven't really suffered except for that time in Israel when I, thought I was doing good with the baseball cap and I wasn't.
Oh, I thought we didn't have coffee.
Yeah, I couldn't find coffee, right. So, they're painful. They're really painful. And, you get a lady on Friday afternoon, she's cooking, she's multitasking, million things going on. And she touches the top of the oven, she's pulling something in. It's painful, okay? And they'll blister up pretty quick, you'll see it. So moist dressings. Let me talk about moist dressings for a minute. I'm gonna link burns to shock, okay?
Can I just ask a quick question?
Let me just finish my thought, and then yes. I'm gonna link burns to shock for a minute. If a large percentage of body surface area is burned, patients will lose which part of the 4 blood components?
Capillaries.
No.
If
What?
what?
Capillaries don't make blood.
What do you say? What?
Patient gets
Pipes.
burned on a large body surface area, large part of their body. Which part of blood is getting burned? Are they losing?
Plasma.
Plasma. Right? If a patient loses a lot of plasma, which type of shock are they going to go into?
Hemogenic?
Hemorrhagic, hypovolemic. You sort of said both,
I said
you combined
It's
them.
actually the password to your YouTube account. Now you gotta learn how to spell it.
Forget it.
All right. So a patient can easily go into shock secondary to a burn. And this is something that they may ask you on a test. Which type of shock?
You can also go into psychogenic, they can faint from the sight of it eventually.
Unlikely that's and again, psychogenic isn't something that's really scary to us. That's self-limiting, that's gonna fix itself. We're talking about shock that's a problem, that needs to be fixed. So just keep that in mind. Large surface area burns could lead a patient into hypovolemic shock. Alright? And if the patient is in shock, then you've got to remember all the treatments for shock as well as all the treatments for the burn. One of the treatments for shock is keep them warm.
Uh-oh. That's a contraindicator.
No, it's not contraindicated. That may be what you've got to do. you may have to keep them warm. Now,
Warm and
here's
moist
the
at the
problem.
same time?
So here's right. So here's the problem. Here's the conundrum that you're faced with. You have a patient with 20-30% burns. We're scared they may go into shock. We've put them in the shower. We've watered them down for 20 minutes. Now we got to go to the hospital, right? How do we wrap them? So there's a rule that if a burn is 10% or less, I personally use 9 because it's so much easier. But the official rule is 10% or less. Then you can wrap them in moist, wet dressings. Because 10% won't cause the shock, the shivering, If they have greater than 10%, you're going to wrap them actually in dry dressings. So you get them all watered 20 minutes, whatever, in the house. Now you get them dry, and you wrap them in sterile dressings. Why are we wrapping them? What is the purpose?
Doesn't get infected?
Purpose is so it doesn't get infected. Burns get infected. Burns get infected, and good burn care will prevent any infection. Okay? Many years ago, everybody that got burned used to get antibiotics. Prophylactic antibiotics, just in case. Today this is seen as very bad medicine. Alright? It's one of the things that was brought up in South Africa as it happens. Today this is not considered good medicine. Okay? Patients should be in a sterile environment. Patients should be really watched carefully in a proper burn center. And use of antibiotics has really been discouraged. And again, even here in New York, last couple burns I took in, I asked, because I like to see where the hospitals are up to in progress and being with the times. And yeah, the last couple hospitals I came to said, no antibiotics. So it's very good to hear that they're...
Even in the hospital they don't give them?
Yeah, in the hospital, yeah.
Unless there's.
Unless there's infection.
Oh, you say even for preventive they don't do it?
Right. Not done anymore. Used to be for everybody. Everybody in the hospital got antibiotics.
And for,
Now-
and just pain control they do?
Yeah, now it's pain control, pain management, yes. That's really important, okay? And again, in the hospital, in your ambulance, keep them sterile. Don't let anything, touch the blisters. Don't break any blisters, as it says here probably, all right? So that's the deal with the 10%, whether it's moist or dry dressings.
This is all for only an adult? That's all I'm asking.
No, it's for everybody.
For a child also, the same care?
Yeah.
They
You
don't
had a
have, like,
question before?
That's what I was wondering about a child. And
everybody.
The difference between 30 and 10%.
And same
Everybody.
percentage?
Percentage is the same?
How often, or what would one do if the patient was unconscious and burned?
Okay, so I don't like getting into what ifs because, we'll never move through what we need to do. If a patient is unconscious, then you most probably don't have the luxury or the time to go to a burn center. You will have to go most probably to the closest trauma center. The question is, why are they unconscious? What happened that caused this burn? Was it purely they're unconscious because of the fire? It's more likely, unfortunately, that they'd be in cardiac arrest from the fire and the burning, as unfortunately we saw a number of years ago in Flatbush, than just being unconscious. But again, these are questions and decisions that have to be made on a case-by-case basis. On the way here, we were actually discussing how do I decide where to take a patient. And I explained very simply, it depends on many, many factors. Okay? I'm talking about in a prime, simple case where you have a patient who is stable, who is able to get to a burn center, does not have an airway issue because that's automatically unstable, does not have a blood pressure problem. They're stable. Their vitals are stable, they've been severely burned, or they're over the 30% second degree, or they're on that, the 4 locations that we spoke about. they go to they go to a burn center.
So when do you take the vitals when approaching a conscious patient that?
Right away.
Before even putting it under cool water?
You first wanna stop the brain.
If they're unconscious, you're not putting them under cold water. You're
No.
getting them out, you're going to irrigate them en route.
Right.
It's a whole different story. These are dealing with conscious patients. Again, most of your burn patients will be conscious. Most burn patients will be conscious.
If the
If they're not
BSA,
conscious, they're usually burnt out crisp.
That's what I said, they'll be in cardiac arrest.
if the BSA is greater than 10%, you're gonna cover the whole body, they're gonna cover them something warm over the whole body?
Yeah, you're gonna wrap the burns in sterile dry dressings, and then again, you'll have to assess for shock. That's a whole
Oh,
separate,
so-
right.
You're not gonna automatically.
No. No, only if they're in shock. Alright, special considerations with burns.
What's this thing with New York, go back 1 second, the New York City protocol, do you wanna address that?
I spoke about it.
No, that last one.
Yeah, I spoke about it.
Bandage closed burns with a saline moistener?
If it's less than 10%. If it's more than 10%, use dry.
Oh, I didn't realize, okay.
Okay? Now, electrical burns. I just want to speak about electrical burns for a minute. Okay? The biggest problem with an electrical burn is the heart, not the burn. Okay? Let me say that again. The biggest problem, you can take a note on this because it's something you need to know. The biggest problem with an electrical burn is not the burn, it's the heart. Now we haven't touched yet on cardiology, but the heart works on an electrical system. Okay? So if somebody gets an electrical burn, whether they stick a fork into an outlet or whatever craziness they decide to do, we consider the burn, but you really, really need to get these patients transported, and you should get a medic to take a look at the heart. Okay? That's really what you should do for an electrical burn.
Short circuit?
Okay? Yeah, it can cause a problem to the electrical activity and conduction system of the heart.
Even if it's a minimal burn.
Again, the burn size will have nothing to do with it. Electrical burns, typically, there will be an entrance and an exit wound, just like in a gunshot, okay? Because the electricity entered the body and left the body somewhere. So you have to look for those. You have to try to find them on a serious electrical burn. You have to understand also that in Europe, they have like a 240, 220, 240 electric supply in their outlets. We have 110 for the most part, except for the special air conditioned ones that we have that are 240s. So 110, not so bad. But the same, the same thing, if they do the same thing in Europe, one of these European countries, where they have 240, 220, whatever it is, running through their houses, can be a lot worse. So, again, we are concerned with the cardiac electrical system. Chemical burns. So this is something you need to highlight, okay? Chemical burns should be irrigated for 20 minutes. 20 minutes, okay? That's how you have to deal with it. Okay, you wait on scene and you irrigate the area for 20 minutes. You should not be seeing too many chemical burns in the house. What is the exception to that? What chemical do we see in the house that causes...
Ammonia bleach.
Okay, so you have the ammonia bleach thing, but what's more famous before Pesach?
St. Moritz.
Very good.
Yeah.
These oven cleaners. These oven cleaners such as St. Moritz, okay? These cause tremendous burns, okay? Really serious burns. I can't understand why they are legal to sell some of these products. They are seriously dangerous. They're dangerous if you touch them. They're dangerous if someone breathes in the fumes from them. It's not a joke. you gotta glove up, but glove up to the elbows to wear these, to use this stuff. Okay? So, we do see chemical burns. We do see chemical burns, alright? I'll never forget a case, I had a lot of chemical burns, but one case that I remember was a young boy, probably 19, 20 years old, and he was working in a hardware store, and there was a can of paint, the paint that you put on the outside of the old-fashioned white refrigerators. Okay, and in those days, you would sometimes need to touch up and whatever, and one of these cans exploded in his face. Okay, he had tremendous chemical burns to the face and to his eyes. Okay, we saved his eyesight. Literally, we saved his eyesight. Okay, because we acted quickly and we did what we had to do. We irrigated. Okay, and we irrigated all the way in the ambulance. We
How do you
irrigated
irrigate
to
it?
the hospital.
How do you irrigate a chemical burn?
Well, in the store there was water. There was a
You're
sink.
supposed to irrigate it with water?
Yeah. What does irrigate mean?
Yeah, but what if it's...
Water. Always use water. Never ever try, to decide. Okay, now I'm a chemist. Okay, so this was a base. So I'm gonna get an acid and I'm gonna neutralize it. No, don't ever try to do
No, but
that.
can't it be dangerous sometimes?
Water, okay? Just water. Okay? Don't try to neutralize, okay? Don't even try to start making, you're not chemists, all right? Please. Okay?
And this is even though it's the person that's gonna hurt the person, right? Will they be in pain when you do this?
What, the water?
Yeah.
It'll be very soothing.
Assume?
Absolutely. Cold water is soothing on a
The
burn.
beginning it hurts, the beginning it hurts,
But
and then after.
they get used to
In
it.
a lot of labs, like they have the sprinklers that if you get burned, you
Yeah.
quickly pull it down.
Yeah.
No, I watch.
Yeah.
What do you think?
Why? Why they have those?
Right.
For exactly this reason. Why those eye wash stations. Right?
Go right in.
Generally, will chemical burns be first, second, or third degree? Like, or just it also depends on what the.
Depends on the chemical, depends on the amount of exposure.
Gotcha.
But is that a
I want that-
universal rating system? The degrees? For chemical, electrical, and...
No, it's all the same. First, second, third for all burns.
Just guys, regarding back to electrical burns, you said that it's heart, it's possible for failure of heart.
Yeah.
How do you identify that right away? Meaning,
You'll,
the patient will
the
be.
patient or somebody will tell you.
The patient will be able to tell you that the heart is an issue.
No. They'll tell you that they were fixing electrical
Right,
thing or they put a fork into the outlet,
Let's say.
right? So now you know there's an electrical burn involved.
But will the patient know that there's an issue with the heart?
No,
Or
not
like
necessarily.
10 minutes later, they'll just collapse.
Not necessarily right. There could be some sort of arrhythmia. That's the word for a problem with the heart conduction system. Arrhythmia. And you'll never
So
know.
any electrical burn, just transport.
Get a medic.
Get a medic.
Get a medic.
Does an
Electrical burn
electrical
should get a
burn
medic.
always have an external wound?
No, not always.
So what is the idea of the entry and?
Yeah, because when there is, there'll be an entry and exit wound.
But
Okay.
not necessarily.
Not
is there
necessarily. It depends. There are so many
variation?
variations. Like when the air conditioning system blew up in this guy's face, right? That was an electrical burn, but he didn't have entry and exit wound. He had a shot, like an explosion that came at him of boiling air and whatever. His whole beard was singed and his face and eyebrows, everything. Okay? That was an electrical burn. Right? But he didn't have per se an entry and exit wound. Alright, this is talking about exactly that case where somebody inhales some sort of boiling hot air and has what we call a respiratory burn. Here's how you can notice it: eyebrows, facial hair, nose hair, any evidence of burn. Yeah, it's fine. Thank you. You need to call for paramedics for these cases. They may lose their airway really, really quickly, and we need to get there really quickly and take care of the airway. We need to make them unconscious and put a tube in their throat and breathe for them. Okay, because that airway could close at any time. You will not get a warning. They will not be like, oh, I think my airway's gonna close now. It's not gonna happen. So,
You intubate right away.
right away.
You can't intubate a conscious person?
You throw it out.
You do, and that's not.
Or you said make them unconscious?
Can you put this down your throat? Don't answer that question. Burn centers. We're not being recorded, right? Burn centers. Look at this. So, I always talk about Brooklyn because, you know, there is nowhere else really, but we don't have one, okay? Apparently, nor do you, okay? So, Queens isn't on the list.
What's Lutheran? Trauma center?
No, burn center. It's a special type of trauma center. We go now to Cornell. When I started doing this, we used to use Staten Island. Okay? It's based on your proximity. Okay? If you guys can get into Queens and go across the 59th Street Bridge, you can go to Cornell. It's not that far. I don't know how far you are from, like, real Queens. What I call Queens.
Jamaica?
Main Street.
I think restaurants.
Dan, where can without the
15 minutes.
See, the man knows.
I think restaurants are the merkaz ha'ir, is
Right.
restaurants.
So,
15-20 minutes.
okay, so you'd go to Cornell. If you live in Borough Park, you're going to Staten Island. Because that's a jump over to Verrazano, right? Over the Guinea Gangplank.
Unless you don't want to pay the toll.
Well, in the ambulances, we don't really pay the toll. If you're up north, you go to Jacoby or Harlem. But Cornell's really good. We always went to Staten Island. Head of Burns in Staten Island was a Jewish guy by the name of Finkelstein. And he was a great guy. He worked with all the Hatzalim guys, and then one day he just woke up dead. So that was the end of that. And a very young guy. Just had a massive MI in the night, and just, that's it. It was done. So we stopped going. We go to Cornell now from Cranleigh.
Impartial.
Alright, let's just, I think I've shown you this before. We'll get to it, alright? I think I've shown you this before. I just want to reiterate that you all need to have a watch on skill nights. Okay, you've learned already how to take vital signs, so you understand the importance of being able to measure seconds with a sweeping second hand. Okay, so there was a sale the other week of watches for like $10 or something. I don't know if it was legit, but there are,
I haven't
you
done
know,
it yet. I'll let you all know.
right.
Well, I know money in my bank account left though, but
What?
I know money in my bank account, but it's nothing to do with that, I'm sure.
Right. Nothing to do. Vital signs, we've done this, right? Skin. CTC, familiar with that? With that, yes, CTC, color, temperature, condition. 3 things we look at. Now do you understand, when I described the skin in shock, I said cool, pale, and diaphoretic, or cool, pale, and clammy? You understand what we were doing there? CTC, right? Color, temperature, condition. Doesn't have to be in that order.
Was that Russian Tavis intentional?
CTC.
No, the order of the vital signs.
No. What does it say? Sperm. No.
Spermine.
Look at the burn.
It's short for spermine.
Seeing as you're paying attention.
Yeah. Okay.
What's condition?
Whatever works.
That's the condition was,
Yeah. Wet, dry, clammy, stuff like that. Heart rate, right? Rate, rhythm, quality. We're gonna practice this stuff. Eyes, pupils equal and reactive to light. Respirations. We have rate and quality. Lung sounds. Here, look at this. Mid-axillary, mid-clavicular. Right? We spoke about these points. Mid-axillary. That's where we're going to take our lung sounds. Mid-clavicular. Okay. Mental status, AVPU. We've spoken about this. This is something really important. AVPU on every patient. Okay, we'll teach you more about exactly how to do it. and of course blood pressure, systolic and diastolic. Sample, have I ever mentioned this in the earlier, right? Let's just run through this again. Sample is an acronym to remind you the questions you need to ask every single patient. Every patient, you need to ask the sample question. Doesn't matter if they stubbed their toe, if they broke a nail, doesn't matter. Or if they're about to die. You need to ask them sample, if you can. All right? So, signs and symptoms. What's going on? Why'd you call us? Where do you feel pain? Do you feel pain anywhere else? What else is bothering you? All that falls into the signs and symptoms, and it's really, really important. I had a patient this morning who was complaining of back pain. Back pain, back and butt pain. Okay, fine. But then I asked her, anywhere else bothering you? Any pain in your chest? Yes. My chest hurts. Oh yeah, where? Boom. Heart, substernal. Okay, good. So if I hadn't asked, because that pain was moderate compared to the pain in the back. All right, we call that a distracting injury. That pain was so severe that she wasn't even focused on the other pains or things that are going on in the body. Allergies. You need to ask every patient this about 6 times in 10 minutes because, I don't know, they lie, they forget. I'm not joking, okay? And they make you look like a fool when you get to the hospital because you'll be presenting to a doctor or to a nurse. Yeah, no allergies, they don't take any medications, and they'll be like, yeah, as it happens, yeah, I forgot to tell you, I'm taking da-da-da-da-da-da-da. Like, really? I spent 20 minutes with you, and you didn't mention that. I asked you 8 times if you were allergic to anything or you take any medications. The best one was once I asked the patient, so you ever had any surgeries? No surgeries. I took off his shirt to listen to lungs, check him out. He's got a great big scar right down the middle. The only surgery typically that, has that scar is a coronary artery bypass graft or a, what do you call it? Cabbage, we call it in medicine. I don't know how you say it. No, there's a way to say that. Like lay people say they had a open heart surgery, stuff like that, right? Bypass.
But he was sleeping.
No, so he's telling me, oh, but that was 20 years ago. I didn't think that mattered. Yeah, right. So that's a huge part of their history, okay? So, people are strange, right? We have to deal with this. We deal with this all the time. Okay, they either lie, or they think it's gonna shot the shidduch, or they don't want to tell you, or they forget. There's so many reasons why you don't get the straight answer. But the best one is when you wheel them in, and then they tell the nurse stuff that they never told you. Ask these questions, and you look like a real moron. Because the nurse is looking at you. Doesn't it say on your chart, no meds, no allergies, no history? All of a sudden, right? They've seen every doctor in New York. It's great. I love it.
I saw
Anyway.
online last night, this girl was writing, her boyfriend's a 911 operator. So she writes, my favorite is how meandering people are, even in the midst of a terrible emergency. They respond to, what is the emergency with, well, the thing is, 4 weeks ago. What is the emergency right now? And they're like, so what happened this morning was, I said to my wife, I said, what is currently happening at this moment? Oh, I'm having a heart attack. And then my second favorite is how specific he has to get sometimes. Like, what is your emergency? I'm sitting in a pool of blood. Is it your blood? Yes, I think so. You know where it's coming from? Probably the stab wound. Have you been stabbed? Oh, yes.
Fantastic. But this is so true. We get stuff like this. We really do. We really do. That's fantastic. All right. Past medical history. Sometimes you get patients that do the opposite. When I was 4, and now they're 82, I had a hernia repaired, right? And whatever. So, yeah, a broken arm. Women will tell you about their pregnancies and all this good stuff. We don't care. Okay? That's not what we're looking for. We want to know about the bypass, the quadruple bypass. We want to know about that. We want to know if they had a thyroid, a cancer, something removed from their body. These are the sort of things we want to know. Major surgery, major diagnoses that they've been given, whether it's thyroid, whether it's breathing disorders and diseases, diabetes,
It mentions about
cholesterol,
hysterectomies
all
also.
this stuff.
Mention the book about hysterectomies, why is that very,
Something
no.
That's having something removed.
Because I mentioned like multiple times about it. That's
Okay.
an important part of the sample.
Again, having something removed, I want to know, I want to document it. That's part of their medical history. Okay? Last thing they ate or drank. People don't understand the importance of this question, so let's bring it into real life. You take a patient, and for whatever reason, they go unresponsive on the trip to the hospital. It can happen. Now they need a surgery, for whatever reason. Surgeons and anesthesiologists don't like performing surgery if they don't know what is in the stomach. Typically, when it's an elective surgery, you can't eat for 12 hours before. Alright? 8 hours, they let you drink some water, whatever it is. They all have different, mishigassen. But they don't want you drinking and eating. So if you're able
Is there a
to
reason
talk,
for that?
yeah,
Which
it can. They don't want you to throw up in the middle of a surgery when you're unresponsive with a tube down your throat, or before they put the tube, or as they're putting in the tube. Okay, so if it's an emergency surgery, and they know that the person ate in the last 2-3 hours, then they can take steps to make sure that they're okay with that. All right? There are things that they can do. It's not the end of the world, but it's better if they know. Events prior to the episode, just think of what's going on in the patient's life. I use this to find out about stressors, whether it's family, work, other environments, anything that could be causing some of these symptoms. Very often, physical symptoms are caused by psychological stressors. So you shouldn't just rule it out and say, that's nothing. It may be very much involved. Want to pause?
Smell.
All right, so we're going to do musculoskeletal injuries, and here we go. Here's a great picture. You don't have to learn this. I just liked it, so I put it in. Okay, this is the bones. See, radius ulnar, femur, tib fib. It's a skeleton made out of the names of the bones. It's good, right? All right, let's go. All right, let's do a quick recap on some anatomy, right, that we need to know. So skeletal system, function of the skeletal system, well, it provides us with shape, it provides a place for muscles to sit, it produces red blood cells. Right? There is a tremendous blood supply within the center of the bones, and as medics, we utilize that. We will drill into a patient's bone, I call it Black and Decker medicine, and I just drill right in so I can get very, very fast access to the circulatory blood supply system.
IO?
So it's really quick. It's called IO, yeah. So that's your skeleton. All right, if you didn't know this by now, get out. Because we've done this numerous times. Alright? You need to know the 33 vertebrae. You need to know them. You need to know the 5 divisions. And you need to know that they are divided into 7, 12, 5, 5, 4.
5 and 5 and 4 are really one.
Just learn these numbers. Learn these numbers, okay? 33 vertebrae. Alright. We should know by now that the arms are made of 1 large bone called the humerus, 2 smaller bones called the radius and the ulna. We need to know that the radius is which? Is it lateral or medial? Always lateral, always the most lateral bone, right? The thumb, most lateral part of the body. Pelvic girdle, made of the ilium, the ischium. I didn't go make you really get into that. We will talk about the ischium in the skill night. And the legs, these bones you must know. Long bone from the pelvis down to the knee is called the femur. Very good. The kneecap itself is the patella. Then we have two bones called the tib fib. Tib fib we call it for short. Tibia and fibula. And then we have.
Which one's the front one? Tibia's in the front?
You mean radial or lateral?
Medial or lateral.
No, it's not even medial or lateral. It's
Anterior or
anterior or posterior.
No, it's the tibia is more medial. The fibula is more lateral. Okay. The calcaneus, I mentioned that bone once. That is the heel bone. It is the largest of the 7 tarsals. You should know that bone. And then again, the metatarsals and the phalanges we don't need to worry about in EMT school. Muscle.
How's there only 14 phalanges?
Count. On each hand or foot. 3 in each finger, 2 in each thumb. 3 times 4 is 12, plus 2, 14.
I thought you meant for like the whole body.
Each hand or foot.
Gotcha.
Muscle, okay, that's skeleton in a nutshell, right? Muscle, there are 3 types of muscle. This is all recap, we've done this. We know this, we've read this, we've studied it. There are 3 types of muscle found in the body. The first one is skeletal muscle, right? What did we say about that? It is voluntary. Good, we know this. Good, good, good. Second type of muscle is known as smooth muscle or involuntary. We don't have to think to make ourselves digest the banana and the apple, right? We don't have to think about it. We don't have to eat either. Good. The third type of muscle that we find is only found in one place.
The heart.
And that is the heart muscle. We've given it a name now. The myocardium. Very good. You must know these 3 types of muscles. You need to know where they're found. All right, some new words, some new stuff. Here we go. Right? Because we've got to learn more stuff, right? Of course. Fantastic. Let's learn about tendons. Let's learn about tendons. I want to draw something on the board. So a tendon, hold on, a tendon is an extension of a muscle, right? Listen very carefully to the wording. A tendon is the extension of a muscle and it joins the muscle to the bone. So it actually fuses and joins the muscle to the bone. As far as you're concerned, for EMS and EMT studies, a tendon is equal to a muscle and a muscle is equal to a tendon. However, the tendons are actually found at the
Meeting.
above the joints, okay? Top and bottom of longer bones, all right? And they join the muscle to the bone. One way to remember this, which we came up with on one particular class, so just go over here to write it, is you are becoming something called an EMTB. Okay, that is the certification that you're working on. It stands for Emergency Medical Technician Basic, right? It also stands for every muscle, tendon, bone.
I like it.
So that's the word.
Okay? So that's just to help you remember, because they will test you on this. You've got to know what a tendon is. And also the problems that we're going to run into at the muscle and tendon level.
So we
Okay?
know that it connects muscle to the bone? So
Yeah. Alright, next is a ligament. Ligament. Ligaments are only found at joints. Okay? Ligaments connect bone to bone. So in this example here, you have a bone here, you have a ligament, and then you have bone here. Right? Same thing here. Bone to bone. Bones are connected at joints by ligaments.
ACL?
Right, we're not getting into any specific ones. Let's just keep it really simple. Tendons, ligaments, cartilage, you don't really need to know much about it, but I put it here. It's just the cushioning between the bones. Don't worry about it too much. Learn tendons and ligaments. Know the difference, know what they are. Okay. Problems that we're going to occur, that we're going to see. Okay? Fracture. Fracture. Let's do this really simply and understand that the definition of a fracture is a break in the structure of a bone. Okay? What does that mean? What is a fracture? A fracture is a break, and a break is a fracture. And I can tell you from doing this for a couple days that whichever word you pick to tell mom that the reason why we're going to go to the hospital to get an x-ray for little Johnny, if you say, well, we need to make sure it's not fractured, you'll hear something like, oh, but thank God it's not broken. And if you say, well, we're just going to check that nothing's broken, you'll get something like, oh, but you don't think it's fractured, right? Because in the real world, they seem, somehow, America has been convinced that these are two different things. Okay? As far as we're concerned, a break and a fracture are the same thing. Okay? It doesn't matter how severe or how minor, they're all breaks and they're all fractures. Okay? So, if there's a break in the structure of the bone, no matter what it looks like, maybe continuous, maybe discontinuous, doesn't matter, it's a break or a
What do you mean by
fracture.
continuous or discontinuous? Is that a full break?
Yeah, or doesn't have to be.
Multiple.
Okay, look at this, green stick fracture, very common in children.
Hairline or whatever.
See, there's only some part of the bone has actually broken. It's not like that. Okay, or like that. Okay? You do not know, you're not responsible for learning all the different types of breaks, what they look like, what happened to them. You're not responsible for this.
But to a certain extent, it is important to know that because one can break through the skin and one won't.
Well, we'll get to
We'll see
that.
that.
I didn't get to that yet. That you will not.
Nobody, even if it
Thanks.
doesn't, can.
Thanks.
Nobody can.
There you go.
Let me talk. I'll answer most of your questions before. Alright?
Oh, see? Right there.
So, two types of fractures, each one, yeah, just shed light for a second so they can see. Each type of fracture has two names. You should be familiar with both names. Two fractures, each one has two names. Closed fracture or a simple fracture. It's not simple. These can be worse than open fractures. Okay? The only reason why it's called closed or simple is because the skin has not been broken. These can be extremely painful and extremely difficult to fix. They need surgery a lot of the time, pins, plates. It's called an ORIF in medicine.
Rods.
Okay? And rods, yeah. So that would be called an ORIF, open reduction internal fixation. That's the medical term for that surgery to fix these. Okay? So, you don't need to know that. You'll not need to know that. Unless a patient tells you they had an ORIF and you don't want to be like, what's that? So, knowledge is good. The more knowledge you get, the smarter you are, the better you'll be.
Open reduction external fracture.
So again, a closed or a simple fracture is where you do not see the bone protruding through the skin. Clear?
Yeah.
You do not see it. The opposite is an open or also known as a compound fracture. Most EMTs and many medics do not know the difference between these words. Simple, compound, open. I heard guys on the radio say, I have a patient with an open compound fracture. That's the same thing.
Redundant.
So why, yeah, redundancy. All right?
What's the stress? I also thought stress and compound is the same thing. Stress fraction, compound fraction. Going upon?
No. An open or a compound fracture is one where you see the bone. Okay? You do not need an x-ray, all right, to diagnose that there is a fracture here, okay? 99% of the time, it will be a closed fracture. You will not know.
Okay.
You go to rule it out, okay?
What is a stress fracture then? Nothing.
Not getting into it. Okay? It's not an emergency.
Huh?
Not an emergency. They're closed fractures. All right? That's all you need to know. So, this is what you need to be worried about. All right? Open compound fractures or closed simple fractures. We'll talk about it. We'll understand how we're going to evaluate it, how we're going to see it. Dislocations. Okay? So before we get to this, let me just make one thing very clear. A fracture can only happen to a bone. Okay? Simple. Now a dislocation can only happen at a joint. Remember, a joint doesn't really exist. Okay? It is the articulation, I used a big word for you, of two bones. That is what a joint is. It's something that's been created, okay, to where bones can articulate. So a dislocation is where a joint has been moved beyond its normal range. Okay? And now it can't move anywhere. It just hangs, let's say, okay? That's a dislocation. That's all I want to say right now. We'll move on. Sprains and strains. These are words that in America nobody understands the definition of these words. Okay? So EMTs must know the difference. Because you gotta know what you're talking about. Or pretend to know what you're talking about. Okay? Sprains and strains, okay? Let's start with strains because this one is easy. Strain is spelled S-T. T. T stands for tendon. Tendons are the same as muscles. So what can you strain? Only a muscle or a tendon. Write it down if you don't know this.
Wait, it's stretching the muscle?
It's a strain. Okay? It's pulling a tendon or a muscle beyond its normal point. The other word is a sprain, and that can only occur, you can only sprain what? A ligament. You can only sprain a ligament. You cannot sprain your leg, your foot, okay?
Ankle.
You're right. You can sprain a ligament in your ankle, okay? Because, and it really, where did I say we find ligaments? Only at joints. So you can't sprain your forearm because there won't be any ligament there holding the bones together. So a sprain will have to be at a joint. It needs to be a ligament. So if someone says, I sprained my ankle, there is some truth to that. Because an ankle is a joint. So that's possible. You could sprain your knee, your elbow, these things, your shoulder, these things could be sprained because there are ligaments there. Wrist is also a joint, yeah. Okay? So, listen, I'm going to repeat this. I need you to study this. There are 4 body parts. There are bones, there are joints, there are muscles and tendons, and then there are ligaments. Each one has its own injuries that accompany it. Bones get fractured, joints get dislocated, tendons and muscles get strained. You need the T. And ligaments get sprained. Remember this.
What was the second one?
Joints, muscles.
Get dislocated.
Wait, what? This is gonna move. No, it's not.
Let's get what?
It should
Joints
move.
get dislocated.
Oh, there we go.
Wow.
Ligaments?
Was it Gashane?
That was good for the 80s.
Yeah.
That to make us dizzy?
I missed it, we do it again.
Spring.
Oh, now look what you did.
Can't click it twice.
It won't do it
Skipping-
again.
Once a night,
Skipping
that's
the
it.
animation.
The mission is only for one time.
This wasn't included in our,
It's coming.
Okay. Glad that excited you. Okay. So, alright, a lot of words here, so don't worry about them. Listen to me. Listen to me. Doesn't matter what it says there, I'm gonna tell you what's important.
Ligaments.
To know what's going on, unless it's a compound fracture and you see the tibia, sticking up through the skin. But taking that, we will assume that that doesn't happen every day, okay? So, assuming that it's just day-to-day stuff at school, stuff at home, stuff at the job, or whatever it is, right? You cannot diagnose which one of these problems exactly is going on, okay? We need imaging. There's no question about it. Yes, if you see the tibia through the skin, I will even allow you to diagnose that that is a fractured tibia. I don't mind. But in 99% of cases, you won't know. You won't know. I can tell you that when it comes to orthopedic injuries, I always decide with myself what the outcome will be, and I would say that I'm not even batting 50%, okay? I'm not doing well in my pre-hospital diagnosis of orthopedic injuries. There are times when I'm 100% certain that it's broken, and it's not. Times I'm 100% certain that it's not broken, and it was. So, with all that being said, this is the rule. General rule, right? Treat every injury as a fracture. You don't know. You don't know. You don't have an x-ray machine yet in the back of an ambulance in New York City. Okay? And it may need more. It may need CAT scan, it may need MRI. Who knows what it needs? But whatever it is, you don't have it in your ambulance. So don't play orthopedist. Even if you were an orthopedist, you would guess just the same like I guess. You may have a better way of guessing, but he's still gonna be wrong many, many times till he gets an x-ray. That's just the way it is. This needs imaging.
Even if it's in holiday.
In New York State, they don't even allow in EMS to use the word fracture or break, because that's a diagnosis. To say you have a broken leg, you just made a diagnosis. You can't do that.
An EMT can't make a diagnosis? No.
Right.
So you gotta
What do you say, possible fracture, whatever?
No, I'll tell you what you gotta say. They are therefore called this: painful, swollen, deformed extremities. Yeah, that's the politically correct way of saying it. You will see that though on New York State like exams and things. Painful, swollen, deformed extremities. Let's look at these words and let's try to understand them. Well, painful, most of you are married, so I don't need to explain what that means. Swollen, I know. Okay, you have no idea. Swollen, being in the army doesn't come close. Swollen, I think we can all understand swollen, right? You see something swell up, you see something that looks like a grapefruit sized, something out of part of their anatomy, that's swollen. We can see that. Deformed. You've got to look at both of their extremities. Not look at it compared to yours. Because they may have some quirky deformity on both sides, and that's their normal. Alright? So look at both. And if you go, oh, that don't look the same as that one, right? That's deformed. Right? So these are things that we can do, right? We can assess for pain, swelling, deformity, and extremities, arms and legs. So we can do that. So that's what we're going to refer to fractures and breaks. Again, the rest of this basically says, treat all these orthopedic type injuries as fractures. You can't go wrong.
But just don't call it a fracture.
Don't call it a fracture, right? All right? Signs and symptoms of musculoskeletal injuries. So bruising, I'll just talk about some of the real, big ones that you're gonna really need to know about. Deformity and angulation. Angulation often means that the arm or the leg is stuck like that in an angle, and they can't move it. Okay, that's called an angulated elbow. All right, they've done something and they can't straighten it or move it.
What would that,
Same thing with the knee. That would be angulated.
so what would that be as a result of?
Again, you remember what I said here?
Break your femur.
Just treat it as a fracture and.
Treat them all as a fracture.
I'll call it.
Exposed bone ends. Okay, so that one gives game away, right? If you see exposed bone ends, okay, that's the one I told you. Yeah, you can diagnose that.
What's the second one?
All right, loss of circulation. We'll get to loss of motion. We'll talk about this. Swelling and tenderness. Tenderness. What is the definition of tenderness? A very important word in medicine. Tenderness. Tender. You need to know this. When you, the practitioner, when you, the EMT, touches a part of their body and they are in pain because you touched, which we call palpated, that's tenderness, okay?
Pain to
So-
palpation. Pain to palpation.
Yes, pain to palpation. That is the definition of tenderness. Pain is them saying, this hurts. That's pain, okay? Tenderness is when you touch it and they go, or you look at their face when you're doing it actually, and if they go like this, that's tenderness, okay?
You skipped the second one,
Yeah, what's the second one?
Yeah.
Coupler.
I want to talk about these. Wait, I have much more important stuff to talk about. Stay with the program. Loss of circulation. How do you, as EMTs, assess circulation in a patient?
Color?
Very good. The most distal pulse that you can find. Right? What's the most distal pulse in the upper extremities? Radial pulse. Very good. So, if their arm looks like, like that, and you can't feel a radial pulse, then you can say, you can't say it's broken. You can say there's a loss of circulation. That you can say. Okay?
you can say facts.
You can say facts. Right.
Deformity.
Okay? So
So you always have to do distal to the.
distal to the injury. Always. Okay, we'll show you on skill nights how to get in the lower extremities the two pulses in the feet. Okay, also. Alright? Remember the names?
Lopez something.
No, that's better.
Tibble.
Femoral is in the groin.
Tibble something.
We're not gonna be doing that.
Tibble Morris, Tibble.
No.
Tibble something.
Yeah.
What? What, the pulse?
Yeah.
It's the Tibble something.
It's the second word's pedis, P-E-D-I-S.
Okay.
No, I can't read
And
it.
the first word.
Posterior tibialis and the dorsalis pedis. We taught you this stuff.
Yes, I studied it.
You need to know this. Okay? Gotta know this stuff. Alright? Good. I want to show you something on the board.
With a D. Right, I copyrighted it, and please do not say that.
I want to show you something on the board.
Now that you're up.
So,
That's too quick for that.
and get rid of the artery from last night.
You clog that up.
So, there are three things that on every one of these patients, we need to assess for, okay? The first one, you understood, pulse, right? And remember, it means a distal pulse to the injury, okay? So that one we call P. Easy, right? Pulse. Now, there's two more things we need to assess for. One is motion. Can they move part of the body distal to the injury? All right? And with the arm and the hand will always be the fingers, and with the leg and the foot it will be the toes. So what you need to do is ask them to wiggle their fingers. And we're testing for motion. So this one we call M.
This one's S.
The last thing we need to assess for is sensory.
Nailed it.
Sensory.
EMS.
Can they feel when you touch? Okay, again, distal to the injury. Can you feel when you touch? And you need to block their eyesight. We'll show you how to do it on skill nights. You block their vision and you touch either their pinky or their thumb. Okay? And you ask them, which finger am I touching? Okay? And if they can tell you correctly, then you have sensory. And this is PMS. PMS is a acronym or Rosh Hashanah that we're going to use a lot. We're going to test it on every single patient that has any type of orthopedic injury. We're going to test it before we apply a splint and after we apply a splint. And I'll get to splinting in a minute. Hold on. Again, these three things are really important. Circulation. We need to assess for loss of circulation. That's P.
P is
We need to pulse.
Pulse.
We need to assess for motor and sensation, motor and sensory, and those are actually neurological deficits. Those have nothing to do with blood flow to that particular area of the body. You understand that?
Even the pulse?
No. Pulse is blood flow. Pulse.
Motion.
Motor and sensory
Are
are neurological. So we're testing to see if the brain is able to send messages all the way to the
You're
fingers.
testing the nerves.
And S is
Sensory. Can they feel what we're touching? So this is the real PMS. People ask why it's called PMS by women once a month. And the answer to that is that mad cow disease was already taken.
Can you talk distal for a minute?
Can I what?
Can you distal? When somebody's distal, so on what parts of the body, someone cuts their hand, so the radial pulse is distal?
No, that would be proximal.
It has to be distal
How do,
further.
how do you look at it, like this or like this?
Always in the anatomical. Come on, you know that.
I do know that.
You do know this.
So this would be,
Proximal. It's no good getting a proximal pulse if the deformity is here and they've got a great brachial artery.
Where else are you gonna
That's
find
not telling you
so what are you
anything.
gonna do if there's
You got a problem.
Oh, okay, oh.
But you can do motor.
Right.
You can do motor and sensation.
Oh, okay.
what are fingers?
So if
Okay.
you get, if you get in the middle of the arm,
Then you do the
brachial?
No.
Radio, always distal.
Further away
Further
from the
away.
heart.
Splinting.
Injury, pulse.
The way we deal with painful, swollen, deformed extremities, the way we deal with them is by splinting them. We will do an entire night on splinting, and you'll be tested on splinting by New York State. This is something will be ongoing skill throughout the course. From when I teach it, we'll continue to practice it and master how to splint properly. Okay?
Jeff made it seem like it's the hardest of the practical exams.
Well, Jeff is in
The
here.
traction splint.
Traction.
Oh,
Okay.
He got scared once by that guy.
Most famous in the world.
Alright,
Who's teaching the class?
You don't have to read the book.
nothing is hard. I'm sure there is somebody out there who became an EMT not as smart as you, that you can think of.
You.
Don't say it out loud. That- no, that doesn't count. That's me. No one else is an EMT here, okay? Alright, why do we splint? Let's stick to theory rather than practice. We'll get to practice on skill nights, but let's think of reasons for splinting. Well, if it's a closed, simple fracture, we have no idea what's going on inside. If we let them move around and do their regular thing, there may be nerve damage, there may be, tissue damage, all sorts of problems going on, vessels. So, a closed injury could even become an open injury, right? If that bone is allowed to move around. So we splint, it's taken very seriously, we do it properly. We also want to decrease pain. And let me tell you something, it really, really works. There are two ways to decrease pain when somebody has an orthopedic type injury. One is for the EMTs to splint the extremity. Splint it properly. This will decrease the pain. The other one is to call me, and I will give them copious amounts of good stuff, all right? But again, when I get there and the EMTs haven't even attempted to splint the patient, I get a little angry. And you don't want to see me when I'm angry, okay? So do what you're supposed to do, okay? If you need me to give them analgesia, that's my pleasure. I will always do that. Little for them, little for me. We can, I might be, all right? So we can share, that's okay. But you've got to do yours, right? Splint. All right, types of splints. So we very rarely use anatomic splints. This is something like wilderness first aid, even general first aid. They'll do anatomic splints. We're going to use soft splints. We're going to use fixation, rigid splints. That's most of our splints. And we're going to learn how to use this guy, which is a traction splint. Okay? So we will learn how to do these. Not a problem. You'll all learn. You'll all get it. All right, lots of words here. I think that I want to summarize what it says here by saying like this. If it doesn't say this, you may just want to take a note. It's really simple. If we're I'm gonna go to the board. We're gonna go to the board. Okay. Now you're gonna learn that I didn't take.
Oh, we were hoping you would leave that very. No, just kidding.
What?
No.
I didn't get really very far in art in school, so okay. It may not look anything like your.
You started though?
No.
Usually you start the math, right?
Yeah. Okay, so here we have typical.
A frog.
No,
Six fingers? That could be an issue or not?
Alright, so here we have an arm.
The Princess Bride.
Deformity.
Okay. Up here we have the shoulder, right? This is the
Join.
elbow. And here we have
Something.
some deformity, some swelling, right?
Pain.
Secondary to whatever situation, whatever happened to our patient. Okay? What do we have here?
Radio pulse.
Wrist, right? So we've got our joints, shoulder, elbow, wrist. So
What's the 6 finger?
how are we gonna splint this? How are we gonna splint this? Is it really bothering you, the sixth finger?
He's not sure if it's two pinkies or two thumbs.
I'm not too good at art.
It's two middle fingers. That's
I would take
I guess that's my true feeling, right? So, What is the rule of splinting? How do we splint? What is the general rule? Theoretically, and then we're going to put it into practice, okay? So the rule is very simple, really. You need to splint the extremity that is affected, right? The affected extremity. What would we call the affected extremity? Forearm, which bones are involved there? Radius and ulnar. Okay? Sometimes we write it like this, RU, radius ulnar, okay? Because the words are difficult to spell, right? So radius ulnar, very good. So we need to splint the extremity, the part of the extremity that is affected. Now, we're going to take, before we do anything, we're always going to remember we got to do PSI. And number 2 now is going to be always PMS. Before we start. Why? Why are we doing PMS before we start?
You know how extreme it is.
Okay?
You wanna see the change?
Right. You want to see if PMS was check, check, check before, and now you put on a splint, and now one of them is gone. Whose fault? Yours. You put on too tight. So that's the only way you can know. So
PMS, split PMS?
wait, number 3 is going to be apply a splint. Now what is the rule of splinting? The rule of splinting says like this. Number 1 is going to be the affected area. Okay? Number 2 is going to be the joint that is proximal and distal to area. This is the rule for a fracture or a bone injury. Okay? Do you all understand this? What are we splinting?
The elbow on this one.
And the wrist.
And the wrist. Very good. So we need to splint from here till here. We've got to get the proximal and the distal joint to the affected area. We see the affected area because
Got the swelling.
we see the swelling. We don't need an x-ray to see swelling. Okay? Now, there may not be swelling. It may be tenderness. How do we find out that it's tender?
Touch it.
Touch it. Or they could tell you, it hurts. Where does it hurt? There. Do we need to touch it? No. They're screaming in pain. That works just as well. So, we need to splint.
Elbow to it.
Elbow will be the joint that is proximal, and wrist will be the joint that is distal. Do we have to splint or immobilize the shoulder?
No.
In this case?
No.
No, we don't. You see the general rule? Afterwards, we always do, number 4 will always be again, PMS. Alright, and then 5 we can put TXP.
That's good.
Transport. Okay? Now, yes, you can mix in other things into here, calling for ALS, carrying them to the ambulance, it's all good stuff. But I'm just talking about the actual. Okay, so you get this? Now, what happens if the injury is no longer here, but the injury is now right here?
That's his shoulder.
The full splint. The full shoulder to wrist.
So what is injured? What are we concerned about? Is it a bone? Is it a joint?
You don't know. You don't know.
We don't know, but they're complaining of pain here, and they're saying, and it's tender there, and there's no swelling anywhere else. So what are we concerned about?
Dislocation.
A joint. Possible dislocation. Okay? So all the rules are the same, except for number 3. So I'm going to go here. So 1, 2, 4, 5 are all identical. Now we're going to do number 3. This is for a joint. So number 1 is going to be the area, right? Which is the elbow. Number 2, I was doing Roman. Okay.
5 is transport.
Number 2, small wrong. Number 2 is going to be the bone that is proximal and distal to the area. Now, in this case, what am I going to have to splint?
Shoulder to wrist, right?
The humerus, very good. We can write that in over here. The humerus and
Are you?
the radius ulnar. Very good. That is.
You splint the shoulder also or not?
Do we need to?
Just the bones.
Only if the humerus was broken.
Very good. This is the rule of splinting. And we will apply this when I teach you exactly how to do it on skill nights. But again, tonight is for the theory.
So you're saying basically if it's you break the bone, you go joint to joint, you break the joint, you go bone to bone.
Yes. Exactly.
When you're doing, let's say it's a shoulder, what do you?
So, very good. So let's say it's a shoulder. So you're just going to have to immobilize really the humerus. Okay? Yes, I could start explaining to you that you also got to immobilize the clavicle and the scapula, but it's too complicated.
Break the bone. You
Keep
break
it
the
simple.
bone. You go
The same goes for the leg.
You break
right?
the joint, you go bone to bone.
Okay? Is that clear?
Yes.
So, you want to swing him around? That, I believe, is what it says here. And if it doesn't,
It should.
tough. It should, right. What happened to my,
Draw a picture and put it on there.
Oh, pause, please. No, it's not fair, it's late.
As long as we be cold.
This part of the lesson.
Go ahead.
Take a bite in between.
The second you smell that thing.
Pause it for this part of the lesson, we'll miss it.
Unless you wanna do this lecture next week.
Hopefully there's no head and neck.
Head and neck injuries.
That's the crack.
Okay, large topic, lot to do, okay? Okay, so, quick review, again, as I always do, review of the anatomy. Very important things that every EMT must know. The name of the lower jaw is? Mandible. Name of the upper jaw? Maxilla. What is the only moving jaw? The only moving bone in the skull. Good. Here is the occipital bone. Okay, the occipital bone of the occiput. And over here we have the mastoid process. I'm going to talk now tonight why that is important. All the other bones you should know, you should learn, but it's not critical, not something that you have to know. Guess what you do have to know?
712. I'm at 4.
Do we know this?
Yeah.
We'll see. New piece of information. The most commonly injured regions of the spine are?
Lumbar.
Cervical and lumbar.
Cervical and lumbar. Where are they? Cervical up here, right by the neck, lumbar, lower back. Okay, so remember this. This is a new piece of information that I have not yet shared. All right, very brief talk about the nervous system. We did speak about it when we spoke about voluntary and involuntary muscle. And basically, this is how it works. It all comes from the brain. The control of the voluntary muscle is there has to be a message sent from the brain. I want to eat the banana. I want to do something. Right? So, the nervous system anatomically is split into 2 sections. We will refer to them from now on as the CNS, the central nervous system, and the PNS, the peripheral nervous system. The CNS, and this is something you must know, contains only 2 things. The brain and the spinal cord. These are the only 2 things that are contained in the central nervous system. This is the sort of thing you would be tested on, okay? So please make sure you know that. Peripheral nervous system
Everything else.
will be everything else to do with the nervous system, whether it's, all the dendrites and axons and all the parts of the nervous system, which are many and complex, and we're not going to get into it. That is the anatomical differences in the nervous system. Now, functional, how does it all work? Basically, voluntary, I want to pick up the banana, right? This is controlled by the somatic nervous system. That's it. That's all you need to know. It's called the somatic nervous system. It controls all those messages that you now understand need to go from the brain to the hand. I want to pick up the banana. I want to put the banana down. All controlled by somatic nervous system. Now, all the other stuff, the part of the nervous system that controls, let's say, the smooth muscle and all the things that go on seemingly automatically, and I use that word specifically, are controlled by the autonomic nervous system. Think of those words very similar. Automatic, autonomic, right? So when you want to digest your food, for example, you don't have to send special messages to your gut that tells you to digest your food. It's seemingly happening by itself. Well, it's actually the autonomic nervous system that's controlling all your smooth muscle, all the processes that are going on in the background by themselves. That nervous system, the autonomic nervous system, is split into two. Okay? It's split into the sympathetic and the parasympathetic. And I think I mentioned these already. Maybe not. One, the sympathetic, deals with speeding you up. Okay? We call it fight or flight. Fight or flight mechanisms. Anything that causes you to speed up bodily processes, to speed up, to make you run, make you react, make you jump. Anything that happens like that needs speed is known as the sympathetic nervous system. The opposite is called the parasympathetic, not the unsympathetic, the parasympathetic, and that is known as rest and digest. Rest and digest, you may read some in certain literature, they call it feed and breed. Same idea, but rest and digest really sums it up better, in my opinion.
So if you want to jump, what is that gonna?
Again, these are not things you want to do. These are things that happen on their own. They're in the autonomic nervous system. Okay? When we give medications, and again, this is why in medic school we spend a lot of time getting into this. Medications act on one of four things. They can either increase sympathetic tone, they can increase parasympathetic tone, or they can decrease sympathetic tone or decrease parasympathetic tone. That's how a lot of medications work. Both legal and illegal medications. They all similarly work this way. One of these things needs to happen in order for that medication to work. Many medications have absolutely nothing to do with this whatsoever, but many do. And in medic school, you will spend a lot of time delving in and understanding deeper and deeper how these medications work, what they do, how they affect the sympathetic or the parasympathetic nervous system.
What is it adding or taking away? Neurons? What's it?
No, it's adding or taking away from the strength, from the power that one of them has. Remember, they're at an equilibrium. They balance each other out. So if sympathetic is increased, parasympathetic will decrease to balance it out.
So sympathetic will be increased if you're in fight or flight?
Yes, fight or flight sympathetic will be naturally increased. And then there are times when we need a medication to make those processes or some of those happen that are not happening on their own.
So if you were to relax the fight or flight, you do that by either increasing the sympathetic
Or by decreasing the.
The other way around. Increasing the parasympathetic. Yes. Yes.
But that's
So-
only, those.
So for example, I'll give you one example because I really want to move on to a lot of stuff. If we're treating asthma, so we're going to have the patient inhale 2 different medications. Okay? One of those medications is going to increase sympathetic tone, and the other one is going to decrease parasympathetic tone. The idea is that they're both going to cause the same thing, but just much stronger.
Why is
Okay.
asthma attack? I mean, the more
I
active
don't want to
asthma-
get into it tonight. Okay, I'm just giving you an example of, again, you will not be responsible to really understand the medications and how they're affecting the nervous system. Okay? This, however, you will be responsible for. So this is a picture of one vertebra, okay? And we know how many vertebrae are there?
33.
33, okay? And the purpose of the vertebrae is to protect the spinal cord. That is its purpose, all right? Just as many bones, purpose of the rib cage would be to protect the lungs, heart, the great vessels, right? Purpose of the vertebrae is to protect the spinal cord. This is the lifeline. This goes between the brain
The rest of it.
and the rest of the body. When we're checking P, not included, M and S, this is what we're checking. When we talk about neurological deficits or neurological problems, this is what we're talking about, right? Is the message getting from the brain down the spinal cord and out into the peripheral nervous system to the toe, the foot, the ankle, wherever it is, doesn't matter. So this is a good picture. And what you really need to understand is that the spinal cord, which sits right in the middle of the vertebrae, okay, goes all the way right up into the brain, into what I told you,
Big
the
hole.
foramen magnum, very good, the large hole. The spinal cord and the brain have a special covering, special protective coating, and we spoke about the abdominal cavity, we spoke about the lungs, we spoke about the heart. This is the last one that you're going to be responsible to know. These are called the meninges. The meninges. So they cover the entire spinal cord and the brain. All covered by these meninges. Now the meninges have 3 layers. Here are the names. Okay, the way I remember them is PAD, P-A-D. Okay, going from inside to outside. I don't think as EMTs you're responsible for knowing them, but it's really useful to know the names. Now I'll explain why. You have the pia mater, which is the most innermost part of the meninges, the arachnoid, which is the middle layer, and the dura mater, which is the outer layer of the meninges. You should understand that the word, which I'm sure all of you are familiar with, meningitis, right? What is itis?
Inflammation.
Inflammation, right? Infection, inflammation. Meningitis is an inflammation of the meninges. How do we test in a hospital for meningitis?
Shot in the back.
Well, it's not a shot, right? It's a needle in the back. Very good. But now we're going to learn how to say it like grown-ups. It's called a lumbar puncture. Lumbar puncture, an LP. Lumbar. I've heard that word somewhere before.
Lower back.
Lower back, right? Lumbar puncture. Okay, so that's what we're going to do. We're going to take a little bit of fluid out. We're going to talk about the fluid in a minute. And we're going to examine it. We're going to send it to the lab. And we're going to say, hey, is it infected? Or is it the way it should be? Okay? And that's how we're going to determine.
Medics don't do that.
No, we don't do this in an ambulance. This is done in the hospital. Okay? And that's how we're going to determine that the patient may have meningitis. For example, there are other diseases, encephalitis, and other things we can get into, but for now, just want to keep it simple.
So the vertebrae
meninges.
protect the spinal cord and the meninges.
Yes,
And the brain.
Spinal cord?
yes,
Those three layers are the same material?
yes.
Just one layer,
Yes,
top
one on top of the other. They have three
Same
different
thickness,
names.
Same thickness, same,
Pretty much. Now, the outer one is probably thicker than the inner two.
and there's nothing in between them, like by the lungs.
Wait, let me explain. Right. What's it called when a woman...
PMS.
Relax, relax. What's it called when a woman
Mad cow.
gets a special type of shot while she's about to have a baby?
Epidural.
Epidural. Dural. Have I heard that word before?
Oh, it's Duramatta.
Duramatta. Where does the needle go? In the...
don't get the epidurals.
Okay, well, we're not
But they
gonna
give
go into that right now.
shots
but-
to, they give shots to knock them out also in the spine.
It was okay, it wasn't so bad, overrated.
So like,
numb it
is this,
first, then
does,
put it
does
in
this
the-
spine go straight through the whole nervous system, right? So they give medication over there to numb the whole entire body, whatever.
That's the epidural.
No, not, there's something else besides epidural.
When they
Spinal
put it in,
tap?
they numb the area. Right?
Spinal tap is
For
a
surgery, they do before
layman's
surgery.
way of saying a LP, a lumbar
He's a
puncture.
layman, this
They
guy.
do
No,
before
you're all
surgery or
becoming
something.
medical
He
professionals.
just drives a big truck.
Before surgery they do.
They can sometimes do,
Anesthesia.
it's an epidural. Okay? So, these are words that you've heard. You may have heard or read in a newspaper somebody had a subarachnoid bleed.
Never heard of that.
Never heard of it. Well, now you will.
A snake or something?
You will. No, none of us is nice. But if you read something a little more medical, okay, you may hear about a subarachnoid bleed. Well, now you'll be like, oh, I know. Subarachnoid means below the
Arachnoid.
arachnoid. So that's a very serious bleed in the brain, right? And now we know exactly where the bleed is.
How do you get that?
Trauma, usually. Okay? So,
Studying too hard.
now, no, it's never happened. Not documented.
The studying too hard part.
Yeah. So, inside the meninges, we have a special type of fluid that is only found around the brain and the spinal cord. This fluid, for spelling purposes, we call it CSF. Okay? Because the actual name is cerebrospinal fluid. Okay, again, you won't be tested on spelling, but you will need to recognize that word. Cerebro means brain. Spinal, spine. It's very simple. Medicine is really simple.
Yes.
Yeah, cerebrospinal, you know where it's found. If you found that fluid in your toes, there'd be a problem, right? So, very simple. Cerebrospinal fluid, we find this in the meninges, right? Within the meninges, covering the brain and the spinal column. Now, this is what we're taking out when we do a lumbar puncture or a spinal tap, whatever you called it, right? That's what we take out and that's what we're looking at. Now, we are going to get into figuring out what to do if we find leaking CSF in one of our trauma patients. That's where we're going with this. Okay? Yeah, it's bad news.
But how would we find out? We wouldn't be.
Call a medic.
Aleph base.
So that's a.
Gonna get to that.
So, there can be many injuries to the spinal cord, okay? What you need to understand, what really is critical, is that wherever the injury occurs to the spinal cord, there will be a problem distal to that injury, all right, downstream. So, if somebody gets a C1, C2 injury,
The rest of
all right, they're done. they're probably gonna be a quadriplegic, they're done. Because everything is lower than that. If somebody gets an injury, lumbar, in the L's somewhere, so they may be a paraplegic, maybe the legs won't work, but they'll be able to breathe, they'll be able to talk, their arms will work, stuff like that. So understand this, okay? And it's bilateral. That means
Both sides.
both sides, okay? Somebody gets a spinal cord injury, will be both arms, both legs, or all four. Okay? That's what's really important to
People
understand.
never lose half their body?
Not from spinal injury.
No,
Okay? 2 words you should know: paralysis. Definition of paralysis is loss of function. Okay? Again, distal inferior to the point, and paresthesia is a numbness or a tingling that also is a neurological problem. Now, you could tell me that sometimes you wake up with tingling. That's because you lay on your arm and you cut off some nerve getting through one thing or another, maybe circulation, whatever it is. When we talk about paresthesia, we're talking about someone was involved in a major injury, a major mechanism of injury, and now they're feeling tingling in their arm or in their leg or whatever it is.
Is that a long-term feeling?
It's happening now when you
At
get
the
that,
time
you'll
of the
see.
injury.
Okay.
Alright, this is a very big slide. There's a lot on this slide, okay? So settle in. Neurological and head injuries, okay? So the first one on the list here is CSF leaking from the nose or the ears, okay? If there is an injury such that the brain has been affected to a point that there is usually like a basilar skull fracture. The base of the skull has actually been fractured. There may be a leak of CSF. And you may see this. But again, this is a major injury to the head. Usually to the head, and you'll see it coming out the nose and the mouth.
Is it a color?
How will you know? How will you know? Because when you see it, it'll be usually accompanied by blood. You'll put a gauze to stop the bleeding, and you'll see a bullseye where the CSF will look yellow on your gauze and will separate from the blood, which will be red. So you will see yellow and red that's coming out. So if you have a patient with a major head injury, again, you'll base it on mechanism, how it happened, put a piece of gauze there, and check for CSF. If you see that, that's a big problem. Let the hospital know, get moving, head injury, okay? We'll talk more about it. 2 things that you can see easily. Battle signs. Battle signs is this bruising here at the mastoid process. And that's why I told you have to know where it is. It's the bone right behind the ear. Okay? Again, basilar skull fracture. There will be blood that will pool over here behind the ears. Again, if somebody has this and they're walking along and everything's good, it's something else. But they were in a major car accident or whatever mechanism, fell off a ladder, pushed out of a window, I don't care what happened to them. But you see this, note it, and know that we gotta get moving. This is bad. The other one are called raccoon eyes. Sorry, raccoon eyes, and this is where you'll see this bruising around both eyes. This can also happen from a pretty simple punch to the nose, and it may not be as severe. We're usually looking at an unconscious patient when we're talking about major trauma.
This happens on both eyes?
Yeah. All right, posturing, neurological posturing. when a patient gets a severe head injury, okay, they may have neurological posturing. Now, it's not as common as it may seem in your textbooks or whatever, but I have seen it, okay? There are two types. One, where the extremities are in towards the patient and locked. Patient's unconscious, had a major head injury, extremities are in and locked. The other one that you may see is where the extremities are out and locked. They have to be unresponsive for this to be called posturing. Why is this so important? So in Scotland, it's a town in Scotland, in Glasgow, which is a city in Scotland, they devised a way of classifying trauma patients, okay? It's still being used today. You can look up which year it was invented, probably 100 years ago or so. So they say that it was invented for drunk Scotsmen, okay? Why we still use it today, who knows? All right, the AFPU system is way better, way more efficient, okay, and way simpler.
Sure.
Glasgow Coma Scale, I'll talk about it, probably have a slide on it soon, but one of the things is neurological posturing, and these two are like the lowest it can get, okay? These score a 1 and a 2, okay? So this one in, this one out, all right? They have names, you called
Is there a
decortica
difference?
and decerebrate, you don't need to learn
So
those.
is there a difference if you see this way, you see that way?
Well, one's worse than the other.
Oh.
I wouldn't worry about it too much. Just, I'm gonna teach you what you need to know about the Glasgow Coma Scale. I'm just explaining to you though, neurological posturing is something that you may see. Last time I saw it was a young man in his 30s, fell down a flight of stairs at work, and I was there, and we were working him up, and I said, the EMT came, and I said, okay, you get a blood pressure, I'll start a line, right? So we both needed to open up the arms like this, and it was locked. We couldn't move him, all right? He passed away a couple weeks later, all right? Young man fell down a flight of stairs, it was a number of years ago. So, it's real.
What happens that it's locked?
We're not getting into that.
Brain injury.
All right, it's brain injury, yeah.
And your
Alright.
body can't move it.
Next, so you got that? Could go in, could go out. Decorticate and decerebrate. Those are the names. You don't need to know the names. Cushing's reflex. I may have to go to the board. I don't have a slide on it.
No, you have on Glasgow Coma.
Yeah, but I don't have on Cushing's. All right, we're gonna go over there. I'm going to erase some of this beautiful. Yeah, you're good, right? So let's talk about Cushing's. Again, this is something that you may see. I have seen this secondary to major head injury, major trauma, serious stuff. Okay, Cushing's. Sometimes it's called Cushing's triad because there are 3 things that occur. Sometimes called Cushing's reflex. Alright? Either way. 3 things are going to happen pretty much simultaneously. If you see these 3 things and the patient had a major head trauma, you better tell somebody at the hospital that's what you're bringing in. Okay? Patient with Cushing's. Number one. First thing you're gonna see is anyone know what that stands for? Hypertension. Okay? We can write it in short, increased blood pressure. Okay? Now, the pressure will increase The reason for this is that there is a bleed now in the brain, and the intracranial pressure, which is usually very low amount, is now, there's no space. The blood is bleeding into the brain, it's taking up space, and the pressure is going sky high. So all the pressures will go up. This is called hypertension. Number one, increased blood pressure. At the same time, you will get also bradycardia, which is a decrease in heart rate. This is completely the opposite from what you would know normally, like in shock. In shock, you will get tachycardia and hypotension. Okay? This is completely the opposite. Special scenario. This is only when head injury, brain injury. Okay? So at the same time, you're going to have hypertension, bradycardia. With me? All right, number 3, you're going to have irregular respiration, RR, respiratory rate. It's going to go very fast, periods of apnea, which means no breathing. It's going to go slow. I'm not going to get into it. There are names for the respiratory patterns. We don't need to go into it.
What's the R?
Respiratory rate. Now, for EMT school, we often just say slowing of the respirations. Okay, instead of irregular, which is really what happens, you could say slowing, bradypnea. If you want a good word to figure out how to spell.
Brady.
Bradypnea. Okay? That means slowing of the respiration.
But isn't it the same thing as heart rate?
No, heart rate is pulse. That's how the heart is beating. How fast, okay? So again, a good EMT comes on the scene, sees a major mechanism of injury, sees there was a problem, right away, gets a set of vitals, patient's unresponsive, wow, blood pressure's sky high through the roof, bradycardic, respirations are all over the place. Let's go, get to a trauma center fast, okay, fast. All right, seizures, nausea, these are lesser things. Seizures are very common after head injury. We'll talk about that in a later lecture. Neurogenic shock. Anybody tell me what that is?
Shock of the brain.
Trauma to the central nervous.
Very good.
1947.
Trauma to the central nervous system. Respiratory arrest, which means what?
Stop breathing.
Stop breathing, right? Where is the breathing center located that tells us to breathe?
The brain.
The brain is a big place. Anyone?
Involuntary.
Nah, can we?
Brain
Where?
stem, the brain stem.
Okay,
Autonomic.
okay. In the brainstem, very good. Who said medulla?
Medulla oblongata.
Very good. That's correct. The medulla oblongata is what controls breathing.
3 parts of the brain. That's the last one.
Okay, good.
That I remember from 50.
You don't need to remember that. But it's good to know.
And then priapism. I googled it.
You did?
I
Priapism.
didn't need to.
He needs to know about priapism.
What can you say? What is neurogenic shock?
Really?
Not what is it, but how does it? What did someone say before? You said it.
Trauma to the central nervous system. We did that in the shock. You were here for the shock, right? Good. Priapism. This is an uncontrolled, unrequested erection of the male genitalia secondary to a head injury. Okay? Right? It is being demonstrated apparently with a highlighter. Right? It's good that the video is facing this way. Okay? Listen, it's something you have to know. Giggles, very funny, but it's serious stuff. Okay? So know what it is. Alright?
How would you would one, I'm saying,
We'll show you how to search for it. I'm not joking.
no, sorry.
Okay, again, pupils.
Wait, what's a sign of neurogenic shock? You talked about that? Signs? I guess we did.
He just
Meet
had
us
baby.
downstairs in the
He just
basement.
had
I know.
baby.
Meet us downstairs in the basement, Charlie.
Moving right along. The only thing that will cause this is a head injury, okay? We can take drugs to cause two like this. We can take drugs to cause two like this. But to get one like this and one like that needs a serious head injury. What's the difference? Oh, because we look in the pupils, we look at every patient's pupils. We want to know, were they doing heroin, or were they doing cocaine, or were they smacked over the head? That's what we want to know. It's very simple diagnosis. Okay, what have they been up to? All right, or if they have, or maybe they just went to the optometrist. That's always an option, as well as crack cocaine. Okay,
I'm
but
guessing that different drugs cause different dilations.
yes,
Yes.
but head injury will cause unequal pupils. That's what unequal pupils look like. This we call one blown, one could be normal size, or one could be meiosis, which is constricted. You should learn these as dilated and constricted. Okay, you don't need the words at the bottom.
But they will always be the same unless you have a head injury?
Yes. Or you've done enough heroin.
They'll still both be the same.
Yes, they'll always be the same. The only way to get them, here, when I wrote in the list, unequal pupils, that's unequal.
And the only way to happen.
Head injury, all right? Brain injury, to be more specific. Stroke can do it also, but soon I'll teach you that stroke is very similar to a head injury. But now we're dealing with trauma, not with medicine, okay? How would you treat neurological injuries? Honestly, get them in the back of your ambulance. Make sure the ABCs, that they're breathing, really work on the airway and the breathing, because that's all you can do.
Even medics, that's basically just the breathing and that's it, or medics have more to do?
Well, we can do more with the airway and the breathing. There's almost nothing we can do in the field.
But it's basically the spine and they have
Right.
to stabilize it.
So, spinal injury, we'll talk about this separately, but extremities. So you understand that you can have a neurological deficit in your arm. Do you understand this?
Yeah, it's worse than that.
Yeah? What would be a neurological deficit in the arm?
Nerves. The nerves.
Right, so you don't feel,
No PMS.
and, right, P there will be.
No motor skill.
No M&S. Right. Alright, stabilization of the spine has gone through a lot of changes, especially very recently in the last couple of years. So we're gonna see what slides I have here and what I'm gonna give you the latest protocol. Sometimes with a small child, remember we told you about the sniffing position?
Yeah.
Right, during CPR? So sometimes when the child is supine and you're caring for the airway, it's very hard to get them in the sniffing position. One way to do it is to put a folded towel or sheet between the shoulders. That would help you a lot. So just remember that with a child. Cervical collars are still being used, and we will still teach you how to use them, when to use them, okay? But they are still being used in New York.
You're making that stress because that.
Because this is now no longer being used, okay?
Do we need to know this?
Yeah, you need to know that it's called a KED, a KED. I will show it to you in skill night. I'll just show it to you in case you go somewhere where it's still being used.
No longer being used in New York.
Okay,
right?
head immobilizers are not being used anymore. Backboards are not being used anymore. Alright?
No?
No. So I will teach you what we do now as opposed to what we did back then.
You mean for spinal injuries, not in general?
Anything, they are not being used.
So how do you try, in this thing that we're doing now, the whole chapter 8 is about backboards.
That was a waste of
What?
minutes.
You just unleashed the New Testament.
That's why
Everybody's
Backwards and I mean.
Not being used. No one is transported on a backboard
That's it,
ever
I'm
again.
dropping
No,
out.
the way they say it is
What does that
they
mean?
take them to the ambulance on the,
You can use it to, you can use a backboard to extricate a patient,
right.
and then they have to be removed from the backboard.
Oh, they don't, okay, they don't put the
They don't
backboard
carry
on
a guy in
and
the
stretcher.
Again, they can be used to extricate a patient, means remove them from a scene, from a tight
And then you
space,
transfer
from
them-
an elevator,
To stretch it.
onto the stretcher, and then it's removed.
Interesting.
We will teach it to you.
Whole chapter 8.
Here's the Glasgow Coma Scale. So basically, there are 3 numbers I would like you to know. I should really write it so you can get it there easily. There's 3 numbers for the Glasgow Coma Scale that EMT should be familiar with, okay?
What's the Glasgow Coma Scale?
Yeah, what is it?
It's a way to evaluate drunk Scotch people.
Evaluate neurological status.
GCS. Okay? It's still in protocol, it's still officially being used on every patient. Okay? Don't go crazy about it. Learn these 3 things, you'll be good. Okay? Number 1. Alright, the highest GCS is equal to 15. Number 2, the lowest GCS is equal to 3. Even if you're dead, you still can get a 3. Okay? There is no 0, there is no 1, there is no 2. Again, you want to Google how many years ago they made this system? It was probably a long time ago. Alright? Number 3 is GCS equal to 8. Ventilate. Okay, it's like a nursery rhyme. GC equal to 8, ventilate. Okay? It's just telling you that if the patient is so bad that they have a GCS of 8 or less, it's not really equal to.
1974.
Yeah, as late as that?
Yep.
That's when it was invented?
Yep.
You have to know what.
I think so, Google.
GCS of less than or equal to 8,
Double check that.
you should ventilate. Okay? Here's how you would calculate it, but really it's on the back of all the ACRs, and if you use a electronic PCR tablet thing, it calculates it for you. You just answer these questions and it'll calculate the number. Okay? This, I believe, has been
Abolished.
abolished. So I'm not even gonna talk about it.
Course it off.
So we're not even gonna deal with how you measure the GCS scale?
Yeah, we're really not.
Oh, okay.
You want me to talk? I can talk about it for a minute.
Begin-
So it goes with eye, verbal, and motor. These are the things. So eyes. When you walk over to a patient, you see how his eyes are open spontaneously? Even though I've been speaking for 3 hours, eyes are all still open. That's pretty good. So your eyes are open, you get a GCS, you get a score of 4 for your eyes.
Nice. Oh, good job.
Okay.
Okay? Now, verbal. I say, what day is it today?
Tuesday.
He says Tuesday. Okay. Is he oriented? No. Is he confused?
Yes.
Absolutely.
Inappropriate.
Is he inappropriate words? No, because he said a day of the week. If I said, what day is it today? And he said banana, okay, that would be inappropriate, right?
If you cursed first.
It's inappropriate. It didn't answer my question. If he said, if I say, what day is it today? And he goes, right? That would be comprehensible. If he says nothing,
He already gets one.
he gets a 1.
Because his eyes were open.
No, his eyes are open, he gets a 4.
Sorry,
Points for doing
You're
that.
adding it together.
So
Hello,
what-
1, 1, and
why is he
1.
getting 1 from that? That was part of
Nothing, look,
It's part of
eyes.
the minus the 3.
Eyes, nothing, 1.
Right.
Why do you get
It's like getting, the highest over there is 60. Oh, it's
15.
15.
These are my points.
Next, motor response. Raise your hand. He does it.
Do it.
He does it.
Oh, I did.
Right. Okay. He obeys commands. He gets a 6. Where does it hurt? Raise your hand, nothing. Where does it hurt? Right? Does it hurt here? And he pulls his hand away from me. Or he pulls my hand away from him. That would be withdraws from pain. Flexion. Flexion.
Punches you?
Decorticate.
Flip.
Extension. Decerebrate. No movement.
3.
Right? That's how you calculate it. But don't make yourself crazy about it. Learn these 3 things. Okay. There's very little here that.
So you guys come into the hospital telling him what number?
Yeah.
Every
I guess
patient?
you
Only
would
No, most patients are 15s or 14s. They don't care. But if you got someone 8 or less,
They have to
you
know.
better know, and you better call them before.
They have a chart in the.
So you're doing a GCS every time?
Every patient.
Really?
Every patient with a brain injury, every patient.
Every patient.
Usually over 8.
So then why is it not important to know that?
It is important, but once they're over 8, you don't have to.
There's 2 questions already.
Again,
99%
You're
of
talking about
patients
the
are.
jet game with them, they were 15.
again, if you're doing a paper ACR, all New York State ACRs has the GCS numbers on the back with the questions. If you're doing it on a tablet, it says
Mental stability.
eye-opening, spontaneous click,
Oh, okay.
responds motor, click. Don't worry.
You don't have to know eye injuries?
No.